Thank you. May I introduce Simon Nichole Boeckmann, Montgomery, and she will talk about vitiligo and psychological comorbidities, a retrospective analysis in an urban population. Please go ahead.
Hello, my name is Simone Montgomery, and I'm a fourth-year medical student at Keck School of Medicine of USC. I will be presenting a study I completed with my mentor, Dr. Netta Elbaluk, titled Vitiligo and Psychological Comorbidities, a Retrospective Analysis in an Urban Population. I have no conflict of interest to declare, and my PI, Dr. Elbaluk, is a consultant for Avita Resell. And here is the outline for my presentation. Skin is the largest and most visible organ of the body, so it follows that the visibility of skin disease can have profound psychosocial effects. Studies have shown that patients can suffer from low self-esteem and social stigmatization, which can lead to or worsen psychological disease, including anxiety and depression. The dyspigmentation of vitiligo specifically can cause profound psychological effects for many reasons. First and foremost are the chronicity and unpredictable progression of vitiligo. This is exacerbated by the often variable response to therapy. Additionally, the effects of vitiligo are frequently present on the face and hands, making the pigmentary changes more immediately visible. While vitiligo occurs in all ethnic groups, it is more visible in darker-skinned individuals, often leaving minority patients more vulnerable to social stigmatization. In one study by Valorant et al., they actually found a bidirectional pathophysiological connection between vitiligo and depression, suggesting somehow the two conditions are intertwined in a cycle that dermatologists should recognize and address. The primary objective of this study was to identify the association between vitiligo and psychological comorbidity. The three secondary objectives were to determine whether rates of depression and anxiety in patients with vitiligo differ in public versus private hospital settings. In other words, does lower socioeconomic status have any effect on risk for psychological comorbidity? Next was to determine the impact of demographics, like gender or age, on the rates of psychological comorbidity in patients with vitiligo. And last was to determine whether body location has any impact on rates of psychological comorbidity. This was a retrospective cohort chart review, and patients were selected based on the following parameters. The first is that they were treated within the Keck Medical Center of USC system, which is a private health system, or within the Los Angeles County Department of Health system, which is a public safety net, between January 2009 and August 2019. The private health system serves a more affluent population, often with private HMO or PPO plans, while the county health system serves a more low-income, uninsured, and underinsured population, which includes a large minority and immigrant population. The second parameters is that patients must have been diagnosed with vitiligo and a comorbid psychiatric condition. All analyses were conducted using STATA 15.1, and for certain analyses, we used national data on depression and anxiety collected from the National Institute of Mental Health. Demographics for each patient were obtained during the chart review. The mean age of all patients was 53.1, with the largest proportion of patients being between the ages of 40 to 64. 66% of patients in the sample identified as female, and 70% identified as Hispanic and Latino. Nearly half of patients were seen by dermatologists, and the most common comorbid conditions were obesity, followed by diabetes and hypothyroidism. The majority of patients did not have Fitzpatrick skin type or vitiligo subtype recorded in their charts. There were a total of 2,638 patients with vitiligo identified for the study. Most patients were seen in county settings. Out of all patients with vitiligo, 6.8% had depression and 5.5% had anxiety. When stratifying by hospital type, at the county hospital, 8.1% of patients with vitiligo had depression and 6.4% had anxiety. The proportions on the private side were significantly lower, with only 3% of patients with vitiligo having depression and 2.7% having anxiety. Additional comorbid psychiatric conditions that were recorded for less than 0.5% of patients included mood disorder with depression, unspecified mood disorder, bipolar disorder, adjustment disorder, and dysthymia. The rate of depression and anxiety in patients with vitiligo at the county hospital was significantly higher than rates of the private hospital. To reiterate, for depression, county rates were 8.1%, while private rates were only 3%. Similarly, the county rate for anxiety of 6.4% was significantly higher than the private side of 2.7%. The depression and anxiety rates at the county hospital were also significantly higher than the U.S. population rates. Rates on the private side were much lower than the national average. When stratifying by gender, the rates of both depression and anxiety in female patients with vitiligo were significantly higher than their male counterparts at the county hospital. Interestingly, rates of anxiety for both men and women with vitiligo at the county hospital were higher than their respective national averages. And on the private side, there were no significant differences for either depression or anxiety in patients with vitiligo when stratified by gender. When stratifying for race ethnicity, rates of both depression and anxiety in non-white minority patients with vitiligo were significantly higher than rates in white patients with vitiligo. Moreover, while rates of anxiety in non-white patients with vitiligo are higher than national rates of anxiety in the US non-white populations, rates of anxiety in white patients with vitiligo were not. Stratification by race ethnicity could not be performed for the private hospital due to a significant amount of unavailable data on race and ethnicity. We also stratified the results by exposed versus not exposed body location. We considered exposed to include face and hands, and our results suggest that there were no statistically significant differences for either depression or anxiety when stratifying by affected body location for all patients with vitiligo in this study. Additionally, we stratified for treatment status and found that all patients receiving treatment for their vitiligo had significantly lower rates of depression. However, this effect was not seen for anxiety. I'd now like to highlight a few take-home points from these findings. Rates of both depression and anxiety in the county population of patients were significantly higher than in both the private and the US population. Numerous studies have shown that lower socioeconomic status can increase baseline risk for depression and anxiety. We believe this is reflected by the higher rates of depression and anxiety in the county population of vitiligo patients in this study. Additionally, females with vitiligo, particularly of lower socioeconomic status, appear to have higher rates of depression and anxiety than their male counterparts. Rates of anxiety in both men and women in the county population are both higher than national rates of anxiety, which again highlights the impact of socioeconomic status on psychological comorbidity. Amongst county patients with vitiligo, who also tend to be of lower socioeconomic status, non-white minority patients with vitiligo tended to have higher rates of depression and anxiety compared to white patients with vitiligo. Many studies have validated that due to many of the social and life stressors that they face, minorities have an increased lifetime risk of developing depression and anxiety, and this fact is reflected in our data. Involvement of the face and hands did not have a significant impact on rates of depression or anxiety compared to those with vitiligo and non-exposed sites. And while we did find that treatment for vitiligo was protective against depression, it did not have the same impact on anxiety. In conclusion, our most important takeaway is that dermatologists should all be screening for depression and anxiety in any patient diagnosed with vitiligo to more holistically address their patient's needs. Additionally, we must consider the impact on risk that socioeconomic status, female gender, and minority race and ethnicity have when following up with those psychiatric screenings. We should also keep in mind that patients with vitiligo may be significantly psychologically affected by their disease, irrespective of whether it's on exposed or non-exposed body locations. Lastly, considering that treatment can be a protective factor against depression in patients with vitiligo, it is important that we offer treatment to all who are interested. This is especially important considering that within our sample population, only 46% of patients have been seen by a dermatologist, emphasizing the need for appropriate referral of all patients with vitiligo to a dermatologist so that appropriate treatment options can be offered. And with that, this is the conclusion of my presentation. As with all projects, there are many people involved to make it successful, and I would like to draw your attention to the acknowledgements I've listed here. I thank you all so much for your time, and I'm happy to answer any questions you may have. Thank you.
Well, thank you very much, Simone. That was a great presentation and a very interesting study. We have time for one question. Were the rates of anxiety controlled by socioeconomic status in the private group?
Yes. So first of all, thank you all for listening to my presentation. And thank you for the question. So we actually controlled for gender and race ethnicity in our calculations. Socioeconomic status was taken from whether or not a patient was at the county hospital versus the private hospital. So when we did our calculations at the county hospital, the statistics from the hospital reflect that the majority of patients come from lower socioeconomic groups. And then the statistics taken from the private hospital indicate that most of our patients have private insurances and come from more affluent socioeconomic groups. So we actually did not stratify by socioeconomic status for each hospital. We use the hospital types as our stratification method.
Very good. Well, thank you very much for that excellent presentation, Simone. We'd like to close out this part of the session and then move into our final session. It's been a pleasure working with my friend and colleague Marwa Abdallah as the co-chair for this session, and we look forward to the rest of the conference. It's my pleasure to introduce our final co-chairs and moderators, Dr. David Rosemary.